What is the role of renal histology in children who develop nephrotic syndrome? First, for the establishment of the exact diagnosis, the cause of the nephrotic syndrome, it aids to a certain degree of active and potentially irreversible lesions or chronic irreversible changes. Renal histology guides the treatment. It also allows the evaluation of the efficacy of treatments and their potential renal toxicity thanks to serial renal biopsies. And finally, it helps in the research when techniques are applied to elucidate the pathogenesis of the disease, including immunostaining and the identification of specific antigens in the deposits. The publication of the ESKDC in 1981 had the aim to identify those patients with minimal change nephrotic syndrome according to the response to initial steroid therapy. And the conclusion was that the likelihood is quite high, although not 100%, that a child with a primary nephrotic syndrome who responds during the 8 weeks of initial intensive steroid therapy has minimal change nephrotic syndrome. However, as you can see, quite a proportion of patients who had on initial renal biopsy lesion of focal segmental glomerulosclerosis responded to initial steroid treatment, up to 30%. And these studies allowed to refine the indication of renal biopsy in children who develop nephrotic syndrome. Children over 10 years may require a biopsy, essentially because steroid therapy may be deleterious after the age of 10 during puberty. Children who develop hypertension before steroid therapy, macroscopic hematuria, low C3, or decreased renal function may need a renal biopsy before starting steroid therapy. Children with extrarenal symptoms, mainly those children who failed to respond to corticosteroid therapy. And previously, it was also indicated in infants less than 1 year, although nowadays genetic studies would be more appropriate. Renal biopsies are also indicated for the follow-up of some diseases and the evaluation of drug-related renal toxicity. So in the idiopathic nephrotic syndrome, as you know, most children with nephrotic syndrome who respond to steroid therapy typically have minimal changes on renal biopsy. And therefore, renal biopsy is recommended only for those patients who do not respond or have steroid dependency. And for these reasons, the results of renal biopsy in children with nephrotic syndrome are not representative of the true incidence of the various histopathological patterns, minimal change, diffuse mesangial proliferation or FSGS, or the true incidence of IgM deposits. So as I said, the majority of patients who respond to steroid have minimal change. And minimal change disease has become synonymous of steroid-responsive nephrotic syndrome, although renal biopsy is not often performed in those patients. Moreover, some patients who respond to steroids show FSGS, and they are called minimal change disease. Some patients who respond to steroids may develop FSGS and renal failure, particularly if the treatment is stopped. So we prefer to use the term of steroid-responsive nephrotic syndrome than minimal change disease, because in most of the case, no renal biopsy is performed. In 1973, René Habib wrote that steroid resistance is the best prognostic factor in nephrosis, irrespective of the histopathologic pattern. And in the adult nephrologist also wrote that the response to steroids is the only prognostic factor in FSGS, irrespective of any of its histopathologic variants. So the response of FSGS to steroids alone in adult patients, 65% failure, 20% partial remission, and 15% complete remission. So there is another category of patients, those who have steroid-resistant nephrotic syndrome. Renal biopsy is then followed by genetic screening in these patients, because about 30% of them have a podocyte gene mutation, which is detected. A complete remission with immunosuppressive drugs like cyclosporine is exceptional, and which is better is that no relapse is observed after renal transplantation in most of them. In non-genetic forms, the association of a calcineurin inhibitor and prednisone induces a remission in more than 80% of cases, and that was shown in a multi-center study in Germany, which was published 2 years ago in CGISN. Renal histology in children with nephrotic syndrome aids to ascertain the degree of active or chronic changes. And this is particularly true in patients with lupus nephritis, where you should consider repeat biopsy in case of persistent nephrotic syndrome or high serum creatinine after induction therapy. Also consider repeat renal biopsy during a relapse if there is a suspicion that the histologic class of lupus nephritis has changed. And finally, consider repeat biopsy if there is uncertainty whether a rising of serum creatinine or worsening of proteinuria represent disease activity or chronicity, because the therapy is not at all the same in both cases. It also had to judge of the potential renal toxicity of treatments. And that is true, for example, in children with idiopathic nephrotic syndrome treated with cyclosporine. In our unit, we performed repeat renal biopsy in 73 children, and 38% of them developed significant tubulointerstitial lesions. These lesions can develop after several years and progress. And they may be observed in patients with normal glomerular filtration rate. And for that reason, we recommend control renal biopsy in those patients every 18 to 24 months, especially those who require a dosage of cyclosporine higher than 5 milligrams per kilo and per day. Finally, research techniques are applied to elucidate the pathogenesis of the disease. And as an example, we can talk about membranous nephropathy. Marie-Claire showed you a nice picture of it. The possible mechanisms of the formation of subepithelial deposits were nicely described by Glassock some years ago. That is the example of the serum sickness, where immune complexes are observed, in amine nephritis, and for planted antigens. And I will say a few words about amine nephritis. Amine nephritis was described a long time ago in 1959, when Ehmann described the occurrence of subepithelial deposits in rats who were immunized with fraction of the brush border of the proximal tubules, but not with glomerular extracts. And subsequently, in the passive model of amine nephritis, the immune deposits were observed very soon after the injection of rabbit anti-rat brush border antibodies, which argue against the role of circulating immune complex. So it was shown that anti-brush border antibodies bound to an antigen on the podocytes, and in 1982, I think, Kerjatsky and Farquhar identified the antigen as an autoantigen, a large transmembrane protein called megalin. And what is interesting is that megalin is not present in the podocytes in the human. So that's an example of antigens of the podocyte. And in 2011, we reported the occurrence of early childhood membranous nephropathy, where it was shown that some children with membranous nephropathy have both circulating cationic bovine serum albumin, BSA, and anti-BSA antibodies, with the BSA present in the immune deposits. And in those children, we could demonstrate the co-localization of the BSA and the IgG anti-BSA in the human deposits. And the role of BSA in the pathophysiology of this form of early membranous nephropathy is not completely solved. BSA, after a partial of absent digestion, maybe it's not, it can be absorbed as a total molecule or fragmented molecule. It's because of, we don't know exactly why it is in the cationic form, but this BSA is probably presented to the T cell with the formation of anti-BSA antibodies. And because the cationic form of BSA, it will bind to the glomerular basement membrane, and the antibodies will bind then to the deposits. So in conclusion, I want to say that renal biopsy has allowed pediatric nephrologists and renal pathologists to meet, to work together, and be good friends. And as examples, you see the picture of, as Marie-Claire said, a very feminine audience in the SIBA Foundation. You recognize Ira Greifer, René Habib, Dick White, Stuart Cameron, I think. Yes? I'll show you better. Here are the pioneers of the Paediatric Nephrology in France: Pierre Royer, Michel Broyer, and René Habib. This is the 50th Glasgow. Here is the 15th anniversary, but half of it was the 25th anniversary in Paris. And you recognize René Habib. Some of them disappeared since Chaim Boykis, Juan Rodriguez Soriano. But you see also Anita Peria, you see Gavina Arnil. And finally, a young man. We really appreciate the way you talked about René in your YouTube presentation. Thank you.